Today we will cover Chapter 16, which is Patient Management with a focus on Patient Control Analgesia, PCA, and Epidural. The learning objectives for this chapter include identifying the indications for PCA and epidural use, identify the equipment that's used for PCA and epidural infusions, explain the PCA settings, including continuous and on-demand options, describe the setup for the PCA, discuss the nurse's role in caring for a patient with an epidural, describe effective client teaching, with the use of PCAs, explain pain assessments and all other relative assessments, unexpected outcomes, delegation, evaluation of client response, recording and reporting, and demonstrate the steps for assessments and interventions for a client with an epidural, such as checking the dressings and infusion tubings. We always provide patient-centered care no matter what we do. This is even more important when it comes to pain management. We must provide individualized care plans by teaching the patient about the prescribed pain treatment by using dignity and respect and caring for the patient. We have to practice patient advocacy when it comes to pain management. If our patients aren't receiving adequate relief from their pain, we have to notify the provider to let them know. We want to empower our patients, encourage them, talk to them, ask them open-ended questions so that they feel comfortable telling us about the pain that they may or may not, the pain that they may be in, and any other symptoms that accompany pain. Remember that pain is unique to each individual. We need to know and recognize all the facts that influence a patient's pain and integrate those into our care plan. We need to recognize that past experiences, culture, personal values, and emotions all play a role in a patient's expression of pain. Culture and ethnicity definitely affect pain. Cultures vary in how they express pain when they seek treatment and what treatments are desirable for them. There are some cultures who tend to be more stoic, whereas others tend to be more expressive. So we need to be aware of those differences. Some cultures may be more okay with using medications, whereas others may seek healers before they actually come in. So we need to know what they're using for their pain, if they're using any herbal remedies or anything like that, or what they think about pain. Some cultures may think that pain is a punishment for something that they might have done. So we need to display caring and concern for our patients so that they're able to share their thoughts on pain with us. The effective communication, again, is really key. And we need to let our patients know that they have the right to have their pain treated. Can we get all patients to a 0? No, but we need to let them know that we'll do whatever we can to get their pain to an acceptable level. So with that, we ask them what is an acceptable level of pain for you, especially those patients who come in and they have chronic pain. We want to know what's acceptable for them. The International Nurses Society on Addictions and the American Society for Pain Management Nursing both support the position that every patient in pain, including those with substance use disorders, have the right to be treated with dignity, respect, and high-quality pain assessment and management. We sometimes have to check our own biases and beliefs about people and be careful about assuming that everyone is a drug seeker, because that's not always the case. When patients come to us for help, we must treat them as human beings, and we must treat them with dignity and respect. Our job is to make observations and assessments and let the doctor know what our findings are. And if they're truly drug seekers, then it will be found out. And we must, again, make sure that we treat everyone with dignity and respect, no matter no matter what their background is. So here's a quick quiz. While caring for a 50-year-old Native American woman, the nurse asked about her pain level after a mastectomy. The patient seems hesitant to talk to the nurse and remains quiet. What action should the nurse take? A. Assume the patient's pain is under control and leave her to rest. B. Insist that the patient consent to a PCA pump to control her pain. C. Call the patient's family and ask them to report the pain level. D. Continue to engage in conversation with the patient. So the correct answer is D. We want to respect any cultural differences. So the nurse should try to engage the patient in conversation because it's important for the patient to report her pain level. And we also need to let patients know the consequences of pain. If a patient's in pain, they tend to tend to not want to move around a whole lot. They tend not to, which can lead to blood clots. Of course, if you're not moving around after you have surgery, they tend not to breathe as deeply. So we may get into atelectasis post-operatively. Initially, pulse rates are increased, blood pressure may be increased. Their ability to heal them, the immune system is also affected by pain, doesn't work as effectively. So we need to let the patients know that it is important. Pain has effects on other body systems, so we need to make sure that the pain is properly taken care of. So safety and pain management. Safety. We talk safety guidelines. We want to monitor patients who receive opioids for signs and symptoms of oversedation and respiratory depression. Sedation, excessive sedation always precedes respiratory depression. So we use sedation scales to assess our patients. And Ramsey, it's in another slide, the Ramsey sedation scale is 1. That's commonly used, and if the patient's at a certain level, then we will institute certain interventions. We want to, because patients are at risk for falls, so if they're taking opioids or certain pain medications, we want to monitor them when they are ambulating, when they're getting up or transferring. We want to monitor potential side effects of analgesics. And what are those potential side effects? Constipation is always one, sometimes nausea, vomiting, depression, respiratory depression, itching or pruritus. And again, the some of the things that we do for constipation, of course, stool softeners. With nausea, vomiting, they may get Zofran or something for their nausea. Itching, there are medications that can be given for the itching, and we see this mostly with epidurals or intrathecal medications or intrathecal spinal infusions or boluses. A lot of these signs and symptoms get better with continual use, and sometimes, of course, if there's sedation and respiratory depression, we will have to adjust the medication dose. We'll have to talk to the doctor about that. Epidural analgesia IV lines should be clearly labeled. They should be, nothing else goes into them, so there aren't any Y ports on those. Every time before a patient receives something through their something IV, you need to trace that line back to the patient to make sure that nothing goes into that epidural line. It's given through the peripheral IV only. Patients who are receiving opioids for chronic pain often require higher doses to alleviate new pain or increase pain because they have tolerance. They develop a tolerance again over time. So it doesn't mean they're addicted. They just need higher levels because of tolerance that occurs. We need to monitor our patients for drug-drug interactions. If they are taking any other sedating medications or medications that have similar side effects. They may have enhanced sleepiness or sedation. If they're on a blood pressure medication and what they're taking is, if they're receiving something through the epidural or something intrathecally, they may have more hypotension. So we have to monitor patients who are on multiple drugs for their chronic pain, especially. And we need to know how often to follow up with pain assessments. If a patient's if the patient's newly on the PCA, the timing is usually within the hour. You're checking on those patients, and it progresses over time. And you should look at the PCA order set that I uploaded for for John Muir, and you'll see how frequent the assessments occur. And they're pretty frequent initially. So pain assessment. This is something that you are all familiar with. I hope PQRST and OCARTS, something that I've used more frequently than the ABCDE. The ABCDE has to do with the actual pain interview. So let's look at PQRST and OCARTS. So P, palliative and provocative, what makes the pain better, what makes it worse. What's the quality? So describe the pain. Is it dull? Is it achy? Is it stabbing? Is it throbbing? Radiation. Where's the pain? Does it move anywhere else? If it's in your abdomen, does it move? Is it stationary, or does it move maybe to the shoulder or around to the back? Severity or intensity. So on a scale of 0 to 10, what is your pain? Temporal factors. Does the intensity of the pain change with time? Is it worse at night? Is it worse in the morning when you get up? And OCARTS is very similar. Onset, when did it start? Location, where is it? Duration, how long has it been going on? Character, again, character of the pain would be, is it dull? Is it stabbing? Is it throbbing? Alleviating, aggravating, what makes it better? What makes it worse? Radiation, again, and then timing, and then severity, same thing as intensity. 0 to 10 scale for that. And back to safety, of course, we'll do the 6 rights and 3 checks and double check allergies for the patient. We want to assess the patient's risk for using opioids, and that risk refers to what's the patient's risk for respiratory depression. Things that put them at risk for respiratory depression are any history of respiratory compromise. So does the patient have a history of respiratory disease? Does the patient have a history of sleep apnea, or perhaps signs and symptoms of undiagnosed sleep apnea, which is more common in patients who have who are obese or who have a thick neck? Does the patient have a history of COPD? That might put them also more at risk for respiratory compromise with using opioids. We want to also verify that the order is clear, that it's accurate, it's complete, it has all of the components, and it's safe for the patient. A lot of places have gone to PCA order sets, and you'll see that when you look at the PCA order set that I uploaded to Canvas for John Muir. It's very specific. It tells you on there if the patient is elderly, the dose is less. If the patient is, or elderly with considerations for renal compromise or liver compromise, as we're thinking about metabolism and we're thinking about renal clearance, they're able to get metabolized and clear the medication. The dose has to be adjusted. The dose is also adjusted for patients who are opioid naive, so patients who don't take take opioids chronically, or those who haven't taken them recently in the past. I think your book says like five or 6 weeks. They're considered opioid naive, so their doses are less because they're more at risk for some of those common side effects. They're at risk for some of those common side effects, so they need lower dosages. And also patients who are patients who are on chronically take opioids need to have higher dosages. So there's a dose on there for those patients, and it's very specific about as far as medications, which the medication that they're having, the dose is very specific. So if we look at the following order on the bottom, morphine 2 to 6 milligrams, IVP is IV push every 2 hours as needed for breakthrough pain. With this order, is it complete? Is it acceptable? Why or why not? The answer is no, it is not. It needs to be more specific. So morphine 2 milligrams, IV push every 2 hours, PRN for pain level 6, 6 or 6 through 8 maybe. And then the higher, or the morphine 6 milligrams, IV push for pain level every 2 hours, PRN for pain level 8 to 10. So it needs to be more specific. It's not recommended that you do a range. It should be specific. Okay. Another part of safety is knowing comparative potencies for analgesics in oral and injectable form. At the bottom of the page, you'll see what is referred to as the equa-analgesic chart. And basically what this chart shows is equivalent dosages among medications and equivalent dosages among routes. So if you administer morphine IV at 10 milligrams, if the patient changes over to a PO route, they should take the equivalent dose of 10 milligrams IV would be 20 milligrams PO. And between medications, basically 10 milligrams of morphine IV is equivalent to 60 milligrams of codeine IV. Okay, we also want to assess a patient's understanding of the purpose and the need for their analgesic, and we want to talk about any concerns or fears that they have because of everything that's been in the news of the recent years about addiction and the opioid crisis. Lots of people are really scared about taking opioids, and I definitely understand it. I understand those fears, but we have to also explain that things have changed with prescribing. Doctors can't just prescribe medications without any thought of when the patient's going to get off of it. They're a lot more restrictive than they used to be. So we don't see as big of a problem. Well, I can't say we won't see as big of a problem, but what I can say is that they're a lot more restrictive in their in prescribing. So if a patient comes in and they had surgery, well, the doctor's only going to prescribe them a certain amount of a narcotic, and then after that, if they're still in pain, they may have to go to a pain management specialist. The doctor will also look at other causes for their pain, and of course, there's all the adjuvants, like muscle relaxers, alternative therapies, massage, heat, ice, those types of things. When I lived in Colorado, there was this thing where chronic pain patients who were taking medications for chronic pain, doctors had to come up with a plan to get them off of it. They had to show that these patients had to have this medication, so they would have had to try other treatments, and the treatments failed. And it was a really hard thing, and I think that it kind of hit patients by surprise, because I had a lot of calls to our clinic. Patients would go in, they had their prescription, they go into the pharmacy to fill it, and the pharmacist wouldn't fill it because they did not get clearance from the doctor saying what the plan is to get the patient off of this medication, or if they had to stay on it, they had to provide justification for that. So yes, the fears are we understand the fear, but there's also the providers are restricted more now, and there's also a need to take medications because there are physiological changes and things that can happen with uncontrolled pain. So now we're going to get into patient-controlled analgesic or PCA. With the PCA, the patient self-administers their analgesic. They have more control over it. They don't have to wait for us to bring their medications to them. And it's used for post-op pain, cancer, pain from cancer, end of life, pain that patients may receive at end of life to make them more comfortable, acute and chronic pain. The advantages, of course, is that it's convenient. The patient is in control. They can administer the medication on their own. Disadvantages, of course, is the risk for oversedation and respiratory depression. And those who are at risk are patients with history of sleep apnea, those who have undiagnosed sleep apnea, such as patients who are obese, patients with thick necks, any patients that have compromised respiratory disease. And as far as safety considerations go, what are some of the patient requirements for PCA use? Well, they have to understand why they are the indication for the PCA. They need to understand when to administer the medication. They need to understand how to do it. So they'll have to be awake and alert enough to actually administer the medication. And then we should explain the safety features of the PCA device, and I'll kind of go over that on the next slide. So with the PCA device, it can be programmed to deliver a continuous amount of the medication, and oftentimes it is morphine, hydromorphone are some of the common ones that are used in the PCA. And what happens is that patients can receive a small continuous dose. They can receive a bolus dose, which they are usually the ones who administer. That's sort of like a PRN dose. So when they start to feel pain, you would instruct them to push the button. Or there can be both, so patients can receive both a continuous dose and a bolus dose. And one of the benefits of the PCA is that the continuous dose provides a more steady state of the medication in their blood, and so the medication is the patients tend to use a lot less of the medication, and they can be more in control. They're happier because they're responsible, and they don't have to wait for us to get pain relief. Okay. And so the programming of the pump, it's programmed where there is a maximum dose that the patient will receive in an hour time period or 4-hour time period. There's a maximum dose, so patient can only receive, I'll just make up a dosage. The patient can only receive 10 milligrams within an hour. And you can kind of look at the order set for John Muir to see sort of an example of what the order may look like. But maximum dose within a hour or 4-hour time period is programmed into the pump. And you can also program in usually a minimal interval between doses. So there's a lockout period. No matter what the patient does as far as pushing the button, they can push the button as many times as they want, but they will not receive a dose if it's within that minimal interval between doses. So it could be patient can only receive a dose every 8 minutes, or patient can only receive a dose every 10 minutes. And usually the button will light up green when a dose is available for use. And so that's something that you can educate your patient on. And again, it's important to let them know that they should push that button when they start to feel the pain. They don't want to wait until it gets too high, because when your pain gets too high, it's very hard to get back under control. So you want to do it before the pain level gets too high. And then some concerns include errors. The pump will alarm to let you know if there's an error, if there's like air in the line or if there's pressure. So when we hear the pump alarming, and we teach the patient to let us know if the pump's alarming, we need to go in and make sure, look at the IV site to make sure it's still patent. We may need to bring in a flush just to check the patency and palpate around as well to make sure it's not infiltrated. And pump failure, of course, the pump not working as it should, or the battery going out, or not delivering the medication, or even delivering too much medication is something that to be concerned about. I need to go back. On this slide, some safety things. We always double check the orders with our MAR, so our PCA order set. We want to double check that with the MAR to make sure that all the settings are correct, the medication name's correct, the dosage is correct, the route, of course. We want to look at the settings for if it's continuous, what that continuous setting is, and program that correctly. We want to know what the bolus dose is, or the demand dose, or both, if they have both, and what the lockout settings are. What's the maximum dose the patient can receive over the hour or the 4-hour time period? What is the interval that the patient is prescribed in between dosing? Again, 2 nurses, double check the orders, the MAR, the medication, and the pump settings, and we want to always make sure that our patients are not allergic to what we're giving them. Okay. This is a setup, and you can take a look at the PCA that we have here. We're going to look at the tubing. So the tubing is different from what you would use on a regular IV. Again, after this is over, I encourage you to kind of take a look at what the tubing, how the tubing appears. It's made in a way so that nothing else goes through this tubing except for the IV fluids that are prescribed to go with it, and it just kind of keeps the line. It's usually at a really low rate, and it just keeps the line patent and sort of flushes the medication through. That's the only thing that's connected to this tubing. Tubing also has to be labeled as PCA tubing. A special label goes on that. And again, before you administer anything, you're tracing tubing back to make sure if you're administering a supplemental dose, you are administering it through the right lines and not through your PCA line. And we'll take a closer look at that when we break into tubes. Delegation and collaboration. So NAPs can only report symptoms to the patient if they go into the room and the patient's excessively sleepy, or they're not alert, or they complain of unrelieved pain. That's what the NAP reports to the nurse. They notify the nurse if the patient has questions. They don't try to answer questions because they can't do that. And of course, they never push the button for the patient either. Okay, recording and reporting. Of course, drug name, the concentration, the dose, when it started, what is the lockout time period, IV solutions that are infused along with it, how much is there, how much is remaining. There may be special forms, special PCA documentation forms in which you have to document on, and you would find that out. You would record any regular assessments that the patient has. So if you, as far as the pain assessment goes, that may be on a flow sheet or any other required documentation. Special considerations. You want to make sure that you give the patient instructions on their PCA while they're pain-free or in a pain-reduced state. This should typically occur before the patient has surgery. That's the best time to do your teaching. You teach them again to push the button when they first start to feel pain, not to wait until it gets too bad, because it's harder to control at that point. Only the patient pushes the button, not the family member, not the NAP, not the nurse. We want to explain what the lockout period is like for the patient. So how much time in between doses and how much they can get within a certain period of time, and that when the button is green, that means that they have a dose available. We want to explain all of that to them. And of course, we want to teach them about non-pharmacological strategies to reduce pain. So we want to teach them about distraction, maybe some guided imagery, positioning, changing positions, using the pillow to cough, splint their incisions if they've had surgery. And then aromatherapy is another thing that might be used. Gerontological considerations, definitely lower doses usually. Adjusted PCA if the patient becomes confused, and the doctor will have to really assess if the patient's a good candidate, because sometimes some patients may not be a good candidate. They may not actually follow through and use it because they are afraid, they're fearful. They may want us as healthcare providers to be in more control and actually give them their medication versus them doing it for themselves. So the doctor will assess if the patient's a good candidate for PCA or not, or if the patient has the PCA and they're not using it, and you notice that they're in pain and you just think that they don't understand or this is not a good option for them, then you can advocate for your patient and get something different for them. Unexpected outcomes. So different route. Okay, so another quick quiz. In relation to pain management, what activity can the nurse delegate to the NAP? So the only thing that the nurse can delegate is B, turning and positioning the patient. The NAP cannot assess, they can't change the pain scale, and of course they can't administer any medication. So our next form of administering medication for pain management that we're going to discuss is epidural. Epidurals are used for acute pain during labor, after surgery, for chronic pain. It's used after surgery for trauma on the chest, surgery on the abdomen, or pelvis, or lower limbs. It is generally safe and effective. Usually very little complications when patients are monitored properly. Medication is administered into the epidural space, which if you look at the diagram, it's the little space that's just in between the vertebral column and the dura mater, which is the outermost covering of the spinal cord. Okay, those outermost meninges that are there. What's administered through an opioid is usually, through an epidural is usually an opioid and a local anesthetic, separately or in combination. That's how it's used. In general, it reduces the total amount of opioid medication required and controls pain that way. So the patient has lower or fewer opioid-related side effects. As the opioid is delivered close to the site of action, so the patient will receive much smaller doses to achieve the same pain relief as if they were getting it IV. Some of the medications that are used for epidural analgesics, some of the opioids that are used, are morphine, hydromorphone or dilaudid, fentanyl, and sufentanil. And these drugs differ in their onsets of action and their duration. The fentanyl and the sufentanil have a quick onset and a shorter duration, whereas the morphine and hydromorphone have a longer onset of takes longer to actually work, and then the duration is also longer with these two medications. Okay, anesthesia is the only anesthesia. So anesthesiologist and nurse anesthetist are the ones who place the catheter in the epidural space, and usually it goes below the second lumbar, but it could also they can also be placed higher at the thoracic level of the spinal cord. And the analgesic is distributed by diffusion. It goes through the dura mater into the cerebral spinal fluid. It's also distributed by blood vessels within the epidural space, and also absorbed by fat in the epidural space. So it works a little. The duration of action is a little bit longer when it's absorbed by the fat. So there's 3 methods of diffusion of medications when a patient has an epidural. The patient is prepped for the epidural when they are either lateral, side lying, or in a sitting position. The shoulders and the hips are aligned and the head is flexed towards the chest as they sit on the side of the bed. And usually the nurse is right there in front of them, kind of coaching them while the anesthesiologist or the nurse anesthetist is placing the IV, the epidural in the back. Catheter placement. Here's another diagram. The first one just short of as an example of where it's placed again between the between the vertebra and the dura mater, the covering for the spinal cord, that outer tough covering. And then the second picture is an example of a long-term epidural. So they can be temporary or short-term, or they can be permanent or long-term. When a patient has the epidural more long-term, it's actually tunneled through the subcutaneous tissue, and it can come out of the side of the back, or either out of the abdomen. So and when it's tunneled, the patient has to have an X-ray to confirm placement. So patients can receive continuous infusions through epidurals, or they can just receive a bolus dose. And those are all initiated by the anesthesiologist or the nurse anesthetist. And we just monitor the patient afterwards. They do the initial. Here are some pictures of the anesthesiologist or the anesthetist inserting the epidural catheter into the back. And they clean, the brown is betadine, where the skin's cleansed. It's a sterile procedure, as you would imagine. Okay, and again, medication administration occurs through bolus injection, and this is from the doctor, the nurse anesthetist. There's also patient-controlled epidural analgesia, where the patient is similar to PCA, but patient receives much better results. It's superior to PCA. And then there is the continuous infusion via implanted pump. Okay. So keep in mind that the catheter can pose a threat to patient safety because of its anatomical location. There's a potential for migration through the dura, so we have to watch our patients closely and monitor them for signs and symptoms that the catheter has migrated. And what it can migrate into that subarachnoid space where the spinal cord is, and the drug levels that are administered through an epidural are much too high for the intrathecal subarachnoid space. They're too high. So patients can have really bad complications if that catheter does migrate. We would monitor patients for headache, really bad headaches, an onset of a bad headache that may indicate catheter migration. If you see any clear drainage on the dressing, that may indicate also catheter migration through the dura mater into the subarachnoid space, and we would need to stay with the patient and call the doctor right away for something like that. Okay, some complications of epidural anesthesia include hypotension, respiratory depression, motor blockade, urinary retention, pruritus or itching, and superficial infection around the catheter. We never administer any other supplemental opioids or sedatives in patients who are on an epidural. because the combined effect may cause respiratory depression. That's for testing purposes. When you look at the order set, it says on there that the order set from John Muir that you don't administer any other supplemental doses unless it's ordered by the anesthesiologist, and that would be checked. A box would be checked for that, and you would give that through the patient's IV. Never ever anything through the epidural. Okay. Epidural lines, just like PCA lines, they should be clearly labeled, and again, nothing else goes through it. Any connection should be taped. Okay. And we monitor patients on epidural for unexpected outcomes, like increased pain, unrelieved pain. We want to assess sedation, respiratory rate less than 8, or apnea, sudden headache that I talked about as well, which may be indication that the catheter has migrated. Okay, this is an example of, just going to briefly look at intrathecal or spinal injections and infusions. This is where the medication or anesthetic goes into the area, into the cerebrospinal fluid that surrounds the spinal cord, and where you see the bulging in the blue area, this is an example of epidural anesthesia in the space there. So when it comes to spinals, a local anesthetic is inserted or injected into the cerebrospinal fluid in the subarachnoid space. It produces autonomic sensory and motor blockade. Autonomic leads to the activation of the autonomic system, leads to vasodilation. Sensory is decreased pain, and motor blockade, the patient's not able to move. It's used for procedures on extremities, procedures such as joint replacements. It's used for surgery on the lower GI tract and the gynecologic surgery as well. The onset is quicker than the epidural, and we want to make sure that the patient is monitored for autonomic nervous system blockade. So signs and symptoms of hypertension. Generally, these patients will have IV fluids going as well to help combat that. And we're monitoring them for bradycardia as well. And this tubing is usually like a different color, usually yellow. There are no Y ports, so nothing else can accidentally get connected to it. Okay, and all the tape if there are connections on the tubing, it should be taped, but there's very specific tubing for spinal injections or infusions. Okay, we're gonna go back to epidural analgesia. Assessment: patient will have to sign a conformed consent, so they are aware of the risk and benefits of epidurals. We assess pain level, of course, baseline vital signs. Patient will be on post-ox or capnography while they are receiving an epidural, so that we know we monitor them for respiratory depression. We'll monitor neurovascular status and sedation level using one of the sedation scales. We want to check the healthcare provides order against the MAR, looking for a medication name, dosage, route, infusion method, any lockout settings, and verify allergies, of course. And on the bottom, there's some contraindications to regional anesthesia. And regional refers to examples of regional anesthesia are epidurals and intrathecal or spinals. So absolute contraindications are patient refusal, the unavailability of anesthesia services because they are the ones who initiate these types of therapies, resuscitation equipment not being available, allergies to the medications that are used, skin infection at the site, maternal coagulopathy. I don't know if any of you guys remember any of those, but things like DIC, things or the patient's at risk for bleeding. The patient used heparin within 12 hours. If there's increased ICP, because pressure can be changed by puncturing, using the needle to start the therapy, the catheter rather. If there's uncontrolled maternal hypotension, so drugs can cause hypotension, or untreated maternal bacteremia. Okay, assessments. We actually just kind of went through that. So this the sedation scale is actually on this slide, and it goes from 1 to 6. And again, you'll have to find out what's used in the facility where you work, but this is a pretty common one that's used. CMST is on there, and that's one of the ones that you use for to check neurological status and circulation. So remember, circulation, movement, sensation, and temperature. All assessments you want to provide for your patients. Delegation. You instruct the NAP to observe the dressing over the site when repositioning and ambulating the patient, just to make sure that the catheter is not dislodged. So if the patient needs to be moved up in bed, you have to be really, really careful about moving them up and not dislodging that catheter. Don't pull them up in bed if they're flat on their back. You may just have to leave them there and kind of get help to get the patient up. The NAP should report any disconnections or leakage from the dressing immediately, and any changes in status. If the patient is not comfortable, still complaining of pain, they don't have sensation of movement, they need to report that to the nurse. Recording and reporting, of course, all the same things that you would record and report with the PCA, the drug, the medication, how much they used. End of shift is the time that you go back to the pump, and you can look at how much the patient used over a specific amount of time. You want to record all of your information and nurse's notes or any flow charts that's used for your facility as well. Any patient teaching or complications and what you did for those complications. And then we'll look at expected and unexpected outcomes. So sudden headache. What we want to do is stop the infusion or the bolus, stay with the patient, and call for help because the catheter might have migrated. Respirations less than 8, or irregular breathing. This is a sign of respiratory depression. So we want to ensure the patient to take deep breaths. We want to stop the infusion, stay with the patient, call for help, and notify the provider. Prepare to and you may have to also administer Narcan. If they're sedated, stop the infusion, raise the head of the bed. You would also do that with a low respiratory rate as well. Stay with the patient, call for help, prepare to administer Narcan for both the respirations and sedation. If the patient's not already on oxygen, there are usually orders, standing orders, where you can put the patient on oxygen. If there's any clear or bloody drainage on the epidural dressing, we want to notify the provider of that. There may be catheter migration, redness, warmthiness, and swelling or exudate. The catheter site, signs and symptoms of infection. We want to notify the patient's febrile, of course, notify the provider. If there's decreased urinary output, urinary frequency, or urgency, or bladder distension, we need to notify the provider. Dose might need to be decreased. We may need to use an in and out catheter. A lot of times with epidurals, patients already have a catheter in place. If there's itching, oftentimes there is medication that's a standing order that you can give, Benadryl. There's another one also listed. And there, for nausea and vomiting, there's usually also a medication that can be given ondansetron or Zofran can be given for that. If it's severe, then the dose may need to be adjusted.